Hi friends, and welcome to this page again today. My name is Mukosha Funga, and today we are privileged to be joined by Dr. Kalima Munalula. She's a gynecologic oncologist here at the University Teaching Hospital, and we'll just ask her a few questions so that we can basically just understand what is cancer in simple terms. Thank you so much for to do this.
Thank you.
We are so grateful. A lot of people are hungry for information like this out there. And the first question to you is, what is cancer in simple terms? Because I ask this because, when I walk around and ask people, no one ever seems to understand what it is really. And so I thought we could bring this question to you so that you could try and make us understand in the most basic of terms as possible.
Okay, so the body has a way that it functions and works and controls cells. So every cell in the body has like a lifespan. So the body is able to determine that, okay, this cell has reached the end of its lifespan, and then mechanisms come in that remove that cell and destroy it from the body. So cancer or cancerous cells are cells that are no longer responding to that control by the body. So instead of reaching a point where they die, cancer cells continue to live, and they grow, and it's like infinity. So really, in sort of like very basic kind of terms, cancer happens when body cells stop responding to the control mechanisms that the body has to eliminate, remove old and cells that are not functioning properly and things like that. So the body this cancer cells escape that, and they continue to exist, like they become immortal. Yeah, so that's what cancer is on a very basic level.
Would you say it's sort of like when a cell just decides to go rogue and then it goes haywire?
Exactly. So rogue cells are cancer cells. So they don't obey the instruction to be removed and to be eliminated and to die. They become indestructible. Yes.
Okay. And how many types of cancer exist for women? How many types of cancers?
Okay, so like you said in the beginning, I'm a gynecologic oncologist, so it means that I work with women that have cancers that affect only women. So that means most of them are from the reproductive organs. So as far as gyn cancers are concerned, we have cancer of the vulva. So this is the structures of the reproductive system that are outside on the body. And then we have cancer of the vagina. We have cancer of the cervix. The cervix is like the opening of the uterus. And then we have cancer of the uterus itself. We can also get cancer of the ovaries. And then there's another type of cancer that we get in women that is associated with pregnancy. That's called gestational trophoblastic neoplasia. So that's a different kind of cancer that's associated with pregnancy. Yeah, so the cancers mostly are in the reproductive organs. So the vulva, the vagina, the cervix, uterus, and the ovaries. Yeah.
Okay. And how many or which ones are the most prevalent in Zambia, would you say?
Okay, so by far the most common cancer in Zambia is cancer of the cervix, followed by cancer of the vulva, ovaries, and then endometrial cancer or cancer of the uterus is the fourth in that order. So it's cervix, vulva, ovary, and then
yeah. And for cervical cancer, I hear it can actually be prevented.
Yes. For cervical cancer, the thing with cervical cancer is that it has what we call a pre-cancer stage. So that pre-cancer stage is one that can be picked if a woman goes to a health facility and has cervical cancer screening. It is possible for us to determine that she has a pre-cancer condition that can then be dealt with. So with cervical cancer, because of that, there's a lot of campaigns for people to, or women to go for screening, because you're better off being caught with a precancer disease that is easily managed, and sometimes in fact it can even be done the same day that you are seen in the clinic. So you go to a facility where cervical cancer screening is done. If the nurses or the healthcare provider finds that you have that pre-cancer lesion, they're actually able to do something about it on the spot, and you don't have to come back for it to be done. Sometimes they need to refer you to a higher level, but most of the time they're able to deal with what they find on the spot. So they see and treat. So that's what we call the system that we are using, where you see a patient and you treat them on the spot. You see and you treat on the spot. So it's very important for women to be caught early on in the cycle, because it's cheaper to treat a pre-cancer than it is to treat a woman that actually has the cancer once it goes that far.
Okay. You hear that, friends? This is why we have started this page, and we want to make just reinforce these campaigns that are already existing, that all women, everyone really should go for regular screening, regular checkups, because for me, having lost my mother, I saw what an end stage of cancer looks like, and I wouldn't want to wish that on anyone. So please, let's listen to the doctors, go for regular checkups, go for regular screening, and then we'll get back to the questions. So cervical cancer can be prevented. Is there any other of these cancers that you listed that can be prevented?
Okay, another cancer that technically can also be prevented is vulvar cancer. The organism that causes cervical cancer and vulvar cancer is the same most of the time. It's human papilloma virus. So women that develop vulvar cancer may have a condition before they develop the vulvar cancer. So if you attend again the healthcare facility and you're having cervical cancer screening, for example, most of all the nurses or the healthcare providers are asked to inspect the vulva as well, to see what is happening on the outside and not just focus on what's happening on the inside. And a lot of the patients that we see here at Women and Newborn Hospital have been referred from facilities like this, where maybe they've got vulval warts or something, that they come to see us, and then when we examine them and we investigate them, we find that actually they don't have cancer, but they have something that we can do, that we can treat them for, so that they don't develop cancer. So it's possible also in vulvar cancer to prevent a woman developing the actual invasive disease if we catch them early, because they have things like maybe warts or something like that that can be dealt with at the beginning before it gets worse.
Yes. And for the rest of them, nothing?
For the rest of the cancers, unfortunately, like for cancer of the uterus, there's no screening method. Cancer of the ovary, again, there's no screening method. But as far as cancer of the uterus is concerned, it usually affects older women. And the first thing they'll notice is that they have abnormal bleeding. So most women who have endometrial cancer or cancer of the uterus are women who have stopped having their periods. You know, maybe they're over 50. So if you are a woman, you're over 50, and you start bleeding, even if it's just bleeding one day, you have to go to the hospital, because it's not normal at all for a woman who has stopped having menses to then bleed. So most of the time, women that are over 50 and are bleeding, the first thing that we think about when they come to the hospital is, do they have cancer in the uterus? So we examine them and we talk to them, and then we see if it's on the cervix or if it's in the uterus. So because of the fact that most women are also uncomfortable when they bleed, they come to the hospital because they say, oh no, I bled, and maybe once or twice, or it's been going on for a month, because they know it's unusual.
I'm sorry
But
to
we
cut
find-
you, but Like for my mother, what you're saying is so true, because for mom, the first time she bled post menopause, it was the time when I was arrested in 2014, and she basically just brushed it aside as, I think I was just stressed because you were arrested. But now listening to you, and that is the message we're trying to put out, is that never brush anything off and say, I was stressed, I'm bleeding, because some of these things are abnormal and we must listen to the doctors.
Yeah, so for endometrial cancer, we usually catch it early, because most women will be suspicious about abnormal bleeding once they've gone into the menopause. So we are able to catch a lot of the women that have uterine cancers early on. For the ovarian cancers, unfortunately, a lot of the women come to us when the disease is advanced. And that's because ovarian cancer, like I said, there's no screening test for ovarian cancer. And the symptoms that people present with are not specific to ovarian cancer. So maybe they'll say they have diarrhea on and off, bloating on and off, or maybe they eat and they feel full quickly. So these symptoms happen with a lot of other things. So you could have diarrhea on and off, and then you may think, oh, maybe something I ate or something, you know. You have a bloated feeling, then you say, oh, maybe something that I ate and things like that. So by the time we see a number of the patients that have ovarian cancer, the disease is advanced. But for endometrial cancer, we usually catch them early because most women are uncomfortable when they bleed after menopause, and they will seek attention when that happens.
Okay. For ovarian cancer, is it also more common in the older women, or it sort of cuts across?
Okay, so for ovarian cancer, interestingly, it affects children as well as grown women. Yeah. So there are some cancers that are like specific, so to speak, quote unquote, for young children. A few months ago, we operated on a 15-year-old who had cancer in the ovary. So there are different types of cancers that affect ovarian cancers that affect women. So some are specifically for younger girls, and then some are more common in older women. But the thing with medicine is that we say never say never. So you can have a young girl actually having a cancer that you usually see in older women, and you know, it's difficult to understand why that would be the case, but it does happen. And sometimes we have women in the reproductive age or towards the end of their reproductive life that are presenting with cancer that would normally be seen in a younger girl. So for ovarian cancer, it's anybody can get it. There are some that are specifically for young girls, and then others, you know, across the age range. Yeah.
Would you be able to make projections like on the population to say how many people it actually affects, cancer?
No.
How many women?
No, you can't. You can't really like make projections as such, because remember we said at the beginning, you know, to use your term, that cancer is like rogue cells. So you don't know who's going to have rogue cells going on. But having said that, I should point out also that there are some cancers that are familial. Okay, so there are two main syndromes, so to speak, that cause women to have like breast cancer, cancer of the uterus, and cancer of the ovary, and then also they may have a colon cancer. So this is like it could be familial. So you find maybe your mom had it, and then your sister has, your mom's sister, and then maybe your mom's brother also had colon cancer or something like that. So there's a syndrome which affects families where they get the different cancers. So ovarian, uterine, breast, or even colon. And then there are also some another familial group of cancers where women are prone to getting like breast cancer, uterine, and ovarian cancer. But what is seen is that in these familial syndromes, the people who are affected get the cancers much earlier in terms of age than women who are they get it and they have no familial problem. So you can have, for example, a 40-year-old woman getting ovarian cancer. She comes from a family maybe which the mother also had it and she got it in her 50s, and then a 40-year-old woman has, and then 40-year-old.
So it keeps.
Yeah, the age is younger for the familiar ones, and then whereas the sporadic ones you find they're in older women, maybe women in their 60s, 70s. Yeah, so it's like that. So you can't really say you can predict or sort of like estimate who gets cancer, but like if it's familiar, then if, for example, a younger woman has an endometrial cancer, like in her 40s, it would be important to do the genetic testing for the lady, and also for her siblings, her sisters, and other first degree relatives, to see if they have the genetic predisposition. I think you know of the actress Angelina Jolie. Yes. So Angelina Jolie, her mom had, I think it was breast cancer, and then a sister of hers, I think, also had breast cancer. So when they did the genetic testing, they found that they had this genetic abnormality that made them high risk for developing the cancer. So she had a double mastectomy. So she had an operation to remove both her breasts, and I think later on she actually had one to also remove her uterus and ovaries, because she wanted to reduce the risk of her getting the disease because of the genetic predisposition. So unfortunately here we're not able to do genetic tests in the public. In the public hospitals we can't do the genetic test, but I think the tests are available with some of the private labs. Yes, the private labs are able to provide the genetic testing, but I would imagine that the cost would be quite high.
That's the thing. And I wonder if NEMA also can cover some of that. Maybe it's a question we'll need to ask.
Yeah, I'm not sure whether they do cover that, but I think the service is available in the private labs.
Okay. It's interesting to know that at least there's that option locally. But also a follow-up question based on what you have just said. Would you then advise women who maybe they are done having children, or some people who don't even desire to have children, to remove their uterus? Maybe?
I think that would be overkill.
Okay.
Yeah, I mean, in the public sector, I can tell you that for example, if you came to our unit as the Gynecologic unit, you wouldn't even be put on our theatre list. Yeah, because you're competing with people that have cancer.
Okay. Yeah.
So if you come and say, "Oh, I'm done having my children, can I have a hysterectomy?" Well, you'd be maybe number 1001 on our list. Yeah. So I think because of that, the important thing is just to be more conscious and aware of yourself. Make sure you do your tests when you're supposed to do them. For women, if you're doing the cervical cancer screening, you're doing it every year or every 3 years, maybe yearly you have a full medical checkup and things like that. But I don't think we're able to offer hysterectomies to patients who just want to have a hysterectomy. We give priority to the ones that actually need that because there's a problem for them. Like I said, on our Gynecologic unit, you're not going to be, I won't even put you on my list.
Because you're overwhelmed, you can imagine. Yeah. So, how, I know there's been a campaign on cervical cancer especially, but how would you say the message is being received? Like in terms of the people that do come here, do they present early? Do they actually come for screening? Or you still have a lot of people presenting late? And what do you, if there are people presenting late, what do you think could be the problem?
That's a very good question, actually. the cervical cancer screening program has been ongoing in Zambia, I think since 2002 or something, for quite a long time. Yeah. But unfortunately, we still see women that come with advanced stage. I think one of the biggest issues that we have to deal with is poor health seeking behavior. So because a pre-cancer stage has no symptoms, you're not feeling sick or anything, most people don't bother to do it. Okay. Then I think the other thing that we need to deal with also is misinformation. So sometimes we find, like for cervical cancer screening specifically, I remember we were doing a campaign in Kafue, and initially the women wouldn't come because I think somebody told somebody that told somebody else that when we put the speculum to examine you, then it will be, first of all, it's very painful, then you will not be able to have any children, and so so women were not willing to come for the screening. So there's a lot of misinformation, there's poor health seeking behavior on the part of the women, so they don't come for the screening because there's no symptoms before, but really, like I said before, you're better off being caught at the beginning of the queue, where something can be done on the spot, than staying at home, not screened, you don't know what's happening, and then once you develop symptoms, that means it's more likely to be cancerous than pre-cancer. So don't wait to get the symptoms, but come before you have any symptoms. That's why it's called screening anyway, because you only screen for a condition that has no symptoms, but you're able to catch it. Yeah. So come for your screening. If you are given the all clear, then you don't have to come again for a whole year. So imagine you suffer discomfort for 15 minutes, and then you are
good for
happy-go-lucky for 12 months, and sometimes even maybe 24 months or 36 months. Yeah, so you don't need to come back for 1 year or 2 years. So I mean, for me, I think that's a 15 minutes of discomfort is cheap, because I'll be comfortable for 24 months. You know what I mean? So I think that's how people should look at it, that the screening is uncomfortable. I always tell my clients when I'm doing the examination that it's uncomfortable, but it's not painful. Yeah, just to put in the speculum and have a look, it's uncomfortable, but it's not painful. Yeah, but if you don't do that and then you get the cancer, then it becomes painful, and then the process is long. There are lots of people that need the care. Our theater lists as long as your arm, so you join a long queue,
or even your
2
whole
arms.
body.
So you join a long queue,
and
we don't know when you get onto that queue, because apart from just the numbers of the patients, there are a lot of things that happen. Sometimes we have problems in the theater. Maybe the machine is not working well, or maybe as you've come, your HB is very low. We can't operate on you because you're not well enough. So like that. So why not sacrifice 15 minutes of discomfort to save yourself all this trouble down the line? Yeah, so that's I think people need to think of it like that.
Let's talk about some of the actual symptoms for someone who has now gotten to that point where they have advanced cancer, because I feel this is also information which needs to be out there, because once people understand just how bad it is, then there'll be that fear. I have seen it from my mother, so very soon with my friend here, we'll be going for screening, and we'll make it very religious. We'll try and tell as many people as possible to also come on board. But what are some of these late stages of cancer symptoms?
Okay, so for cervical cancer, for example, if you bleed when you're not supposed to be having your period, you need to have that checked. If you have a male partner and you bleed after sexual intercourse, you need to have that checked. If you have a foul smelling watery discharge, you have to have that checked. If you have back pain with any of these things, you have to have that checked. And then there are some women that when they bath and clean themselves have the terrible habits, which they shouldn't do, but they still do it, of inserting their fingers into their vagina, and then if you find there's bleeding, you need to have that checked. So mostly it's abnormal bleeding for whatever cause, whether it's outside your period or too often in the month, you need to have that checked. Sometimes it doesn't mean you've got cervical cancer if you have abnormal bleeding. It could be anything, but it's better to have it checked so that you know what it is. If it's not cervical cancer, then that's well and good. The doctor will tell you what it is and they'll manage it for you. But if it's cervical cancer, then we need to know that it is, and then again we'll manage it for you. So that's for cervical cancer. So those are some of the symptoms. For the other ones, like I said, like for endometrial cancer, because it happens mostly in women that have passed menopause, if you are past menopause and you bleed, you need to have that checked. Yeah, because it's abnormal for a woman who's past menopause to bleed, even if it's just once, one day. Yeah, you need to have that checked. Also, in older women, if you have like after menopause, a watery discharge, again, you need to have that checked, because sometimes you have patients that have a watery discharge and it's a cervical, it's a cancer in the uterus. Yeah, so you need to have that checked. I think the important thing that everybody needs to understand is that you need to know what your normal is in order for you to be able to recognize what is abnormal. Yeah. So you need to be aware of yourself and conscious about yourself. Then you know that this is not me. There's something wrong, and you go to the hospital. If sometimes women go to healthcare facilities, and the person that they see does not take their symptoms seriously, you're free to go somewhere else and get a second opinion. If you
but
really
it should be yourself, like saying, "Oh no, I don't feel comfortable.
Yes. Let me go and see a doctor." If the doctor seems like they're not telling you something that is making you comfortable or explaining what's going on, you're free to go and see somebody else. I think it's always good to get a second opinion, because sometimes people need to remember also that sometimes as doctors we may be wrong about what we think, about patients, and we may brush off patients that we think this patient is very troublesome. She's always coming for all sorts of things. So yeah, so we may be wrong. So that's why I'm saying you can go and get a second opinion with somebody else. But really, you need to know what your normal is in order for you to recognize what is abnormal. Yeah. And don't stay at home. And then with the vulvar cancer, some of the things that women present with is like they have an itch on the vulva, and then maybe a watery discharge. Sometimes you can get discoloration. So maybe the skin on your vulva starts getting white, yes, or it's looking darker. You've got dark patches, and there's an itch. You need to go and have that checked. If you go to the hospital and the person that sees you does not actually examine you, and maybe they prescribe something for you, then I would go and see somebody else. Yeah. So don't, if you have an itch or something like that, don't sit if somebody gives you some medicine without actually examining you, because they need to see what's going on. Yes, I've seen a lot of women who they had symptoms, they have an itch, and then they go to the healthcare facility, and then someone prescribes some ointment for them to use, and then they go, and then they come back after 3 months, and then they're given something else, and then they go.
In that case, then the doctor thinks it's a thrush or something?
The doctor doesn't see it.
Okay.
You see, they don't examine it. They'll say, "Oh, I've got an itch," and whatever, and they say, "Okay, try this." And then they'll go home, and then they'll try it. And then eventually they come, and then they have a lesion, they have an ulcer or something, which so time has been lost. Yeah. So if you go to a hospital and the doctor doesn't examine you but prescribe something, it's always good to go and get a second opinion. Somebody should actually examine you, even when you say maybe you have my tummy is sore, coughing or something. The doctor should listen to your chest. They shouldn't just prescribe something without listening to it. That's what I'm saying. They should examine you. So whether it's in the chest.
Let's talk about these examinations. So, our society, people are so, what's the word? Like so reserved, so like there's, for lack of a better word, most people tend to be prudes. Like anything nudity arrangements, the doctor coming to check you down there, people will shy away from that. So I think maybe you need to encourage people to say you need to do this.
Yeah. So like I said, for me, because I work with gyne cancers and things like that, it's good to see. Yeah. You always need to see what's what the patient is complaining about, because sometimes sometimes it may not even be anything. I've seen patients that come to the clinic, they've been referred from one of the other health facilities here in Osaka, and they come to us, and the referral form has been written, and then I look at them and I say, but why did they even send her? But then you see, it's important because the other person thought, no, maybe this is something more than I can deal with. Okay, then they send them up to the next level. That's good. Because now I look at them, I examine them, and I say, you needn't have come here. But that's good, because they referred them up to the next level. So it's, for me, looking at a woman and examining her is very important, because that's how I can tell, like, okay, is this something big? Is this something we can do something about? Or no, I can't do anything about this, or whatever it is. But I always have to see what they're presenting.
What's going on.
So I and I don't know, I suppose because I'm a woman, so a lot of the ladies are sort of like comfortable. Yeah, but we also have, and it's a fact that a lot of the gynecologists that we have are actually males. So you don't, as a woman, I don't think you should feel so bad about being examined by a male, because most of the time they're examining you as a professional, and they want to do their best to help you, because when you come to the hospital, you're coming for help. Yeah. People should not feel too restricted about the lower half of their body. Yeah, just come, be seen. Yeah, and if you're given a clean bill of health, then that's good.
Yeah. And then also, talking about the late stages of cancer, it does at some point begin to attack other organs, right? And that's what leads to some people ending up dead. I don't know, like from my layman observation, this is what I think. But is that the case?
Yes. So what happens with cancer is that it spreads, and the cancer spreads. We say by direct extension, and also through the blood, because the cells, remember, they are cells, and cells are small. So the cells can go into the blood vessels. The cancer, as it's growing, also has an ability to like grow new blood cells that previously were not there. And these get joined to the already existing blood cells, and then that way cancer cells can move to the rest, to other parts of the body. They can also move through the like lymph vessels. So these are different type of vessels that are found in the body. So by direct extension, for example, in cervical cancer, initially the cancer will only be on the cervix, then it starts spreading outwards. It will go to the bones, it will go to the bladder, it will go to the rectum. So sometimes women who have advanced cervical cancer will have pain in the back because it has gone to the bones and it's affecting their bones. And then as it's spreading outwards to the bones, it causes problems with the ureter, which is a structure that brings urine from the kidneys and helps pass the urine. So those structures get blocked, and because of that, it starts affecting the kidneys. And then when the kidneys are affected, because there's one component that helps us produce the hemoglobin that is required in the blood, then that production also is affected. And then if the cancer cells get into the blood, they now go to other parts, not just for cervical cancer, but for other cancers. So they'll go to the liver, they'll go to the lungs, and sometimes the cancer even goes to the brain. Yeah, so all this happens because the cancer cells are getting into the blood and then moving around the body. So that's called, we say that's metastatic disease, so it has spread.
Okay.
Yeah, so when a patient comes and we examine them and all that, we are able to stage. Cancers have 4 stages: stage 1, 2, 3, and 4. Depending on the extent to which the disease is present, then the patient could be in either 1, 2, 3, or 4. And depending on the stage, we're able to do something about it. For example, in terms of cervical cancer, if a patient comes to us in stage 1, usually we are able to offer them an operation where we remove the uterus and the cervix.
And then they're cured.
Most of the time they're cured. And then if they come to us in stage 2, 3, or 4, we're not able to operate, but they can go and get treatment from the Cancer Diseases Hospital. Yeah. And then the other cancers, like cancer of the uterus, for example, if it's stage 1 or stage 2, most of the time we're able to operate. But if it's gone to stage 3, meaning it's affecting other organs, we're not able to operate. Ovarian cancer as well has stage 1 up to 4. Again, and for ovarian cancer, the thing is that we're only able to know the stage when we take a patient for the operation. We can't stage them before the operation is done. So sometimes what we do is a patient may be too ill to have an operation because it's major surgery. So we'll go and just get a small piece of the cancer. So that we know what type it is, and then our colleagues can know what type of medicine to give them. Then they'll get the medicine, and then after they've improved in their condition, we take them for the operation and to do the operation. But then we can only tell the full stage once we've taken them to the theater. We can't tell the stage before that.
Yeah. And when we excuse me, when we watch movies, we see sometimes someone goes to the doctor and then they'll be told, it's already late stage, you only have 4 weeks to live. Are we able to make such projections here?
No. I'm not very sure. I suppose the time that a patient is given is based on like statistics that are obtained from different people who have that same condition and diagnosed at that point, and then they see how long after the person got that diagnosis did they continue to live. One of the statistics that's collected for the different cancers is what is known as a 5-year survival. Yeah, so depending on the cancer and the stage, the 5-year survival is different. So the 5-year survival is like very loosely, if a patient is diagnosed with the cancer on day 1, after 5 years, how many of those people who were diagnosed with stage 1 on day 1 will still be alive? And then how many who diagnosed with stage 2 after 5 years will still be alive? So that's like the 5-year survival. Yeah. So different cancers have different survival rates. Then the other thing also with cancer is that sometimes they may get, like I told you that there's one cancer that we deal with that is associated with pregnancies. Yeah. So that cancer is very responsive to chemotherapy.
Okay.
Yeah. So patients who we find have that condition, when they get the chemotherapy, a lot of them recover. So the 5-year survival is quite good.
Okay. So for when you're pregnant and then you're found, can you go through chemo while you're pregnant, or you wait for the lady to deliver? Or how
So
does
that
it work?
depends. That depends. For example, with cervical cancer, if you have cervical cancer and you're pregnant, depends the stage of the cancer and how far gone you are with your pregnancy, and also what your desires are as far as that pregnancy is concerned. So if, for example, we find you with stage 1 cancer and you are maybe 6 months pregnant, we'll say, okay,
We can wait.
we can wait. Yeah. If we find you with the stage 2 cancer and you are 8 weeks pregnant, then now we need to talk with you and ask you, do you want to wait for 32 weeks to get your treatment, or you want us to start your treatment now? So it's not such an easy decision to make. You have to talk to the patient.
Pregnancy also tends to be quite, it just goes bizarre sometimes on the body. Does it also affect how the cancer is growing? Like, can it maybe grow quicker when someone is pregnant? Or?
For cervical cancer, no.
Okay.
For cervical cancer, no. But when I say that there are some cancers that are associated with pregnancy, there's this particular cancer is you get pregnant, but the baby doesn't form.
Oh.
Yeah. So the baby doesn't form, and then because of that, if it continues like that, that condition can later on become cancerous, or it predisposes you to getting cancer. So we see women who maybe you are married and you think you are pregnant, you've not had your menses for 2 months, you go and have a test at the clinic and they say, oh yes, you're pregnant. So you think, okay, I'm pregnant, and then maybe 3 months down the line you think, oh, maybe there's something amiss. Then when you go to the hospital and you have a test done, the pregnancy test on the urine will come back positive, but when we do the ultrasound, there's no baby inside. Yeah, so that's the problem. That's the cancer that I'm talking about. Yes. So now that type of condition is very responsive to chemotherapy, and a lot of women recover when they are treated, and some even go on and have a normal pregnancy and a normal baby after they've been treated like that. So when I see patients that have that, I always tell them that, okay, you are pregnant, but the baby didn't form. That's a very sort of like basic way to explain, because sometimes people will think, oh no, banamo bela mwana. So we see that a lot in younger girls and also older women. So women maybe who are in their 40s and are getting pregnant, they're at risk, increased risk of having that type of abnormal pregnancy, as well as girls that are younger, they're at increased risk of having that type of pregnancy. Yeah, so the two extremes of age have that.
How common is that also?
Well, that is also, we see like here at Women and Newborn, I think we see one such case every week.
Every week?
Two or three times a week. We see that a lot.
Okay. So when someone is pregnant, they've stopped having their menses, does it mean they haven't been doing abdominal scans to check? Or
well, sometimes some people, it's not everybody that's goes and has a scan to look at what's going on. But most of the time, by the time they're getting to maybe about 3-4 months, they may bleed because there's something off. Then they'll come to the hospital, and then we'll find all of them. This is not a usual pregnancy, and we'll manage them appropriately.
Okay. Yeah. Okay. Thank you so much. I have a last question, and this one is more sort of personal for you. Like, I since we had Mom here, just going through that, seeing her situation, other patients, you go through this all the time, and you're a doctor. You see people who maybe you have to communicate with them that, oh, unfortunately now there's nothing we can do. How do you handle that, and how do you sort of keep yourself grounded and your emotions in check?
That's an interesting question. So I think one thing that when you go to medical school that you learn is that you need to what's the word? You have to sort of like detach yourself from patients. You have to see things from the patient's point of view, but then also I think it's important to let patients also sort of like understand. I've had situations where a family have brought their mom, and you can see that this is we've tried, but this is the end. And then I've spoken to family members and said, we can't do much for your mom, but we can make her comfortable. So, and then sometimes I've had to have difficult conversation where I'll tell the patient, the patient's caregiver, like the bedside, and say, if you see this happen, don't panic and call the nurse. Because sometimes our nurses get a lot of stick from bedsiders and say, no, the patient was dying, the nurse didn't do anything, and whatever. But sometimes I've had to tell patients that no, the nurse should not do anything. And when you talk, I think sometimes when you talk to family members and explain what is happening, they may actually be happy that you had that conversation with them, and they understand, so that if they call, if they see something is going wrong, and they don't call the nurse, then they don't feel like, no, the nurse neglected our mother and things like that. Of course, there are people who say, no, the way the nurse spoke and things, and like I said already, we're human beings, and sometimes people have challenges dealing with end of life issues. So I try my best to sort of like not lie, tell the truth with as much understanding as possible, so that the family can also see that, okay, the doctor's tried, but we're getting to the end, and we're going to make them comfortable. So I'll tell them like, no, we'll give them painkillers so that they won't really be in pain. But we're not going to come and the blood bank and say, bring blood, let's transfuse. Yeah, we're not going to do that. And the family should also understand that no, they are doing that because they don't want to give us the false hope. I know that people always talk about, but there are miracles and things like that. And yeah, there are miracles, and I have seen. You can't work on a labor ward without seeing miracles. We see that all the time.
Okay, that's a story I'd like to hear.
Yeah, we do. You see that all the time. But then again, I think it's also good as medical care people to be honest with patients and their families. I've spoken to families sometimes where I've said, if you want to go home with your mom, you can go home with her, and then some families, I think, are a little bit queasy about, they don't want somebody to die in the house. So they say, no, kids, okay. It's okay, you can stay here. Yeah, and then you come back maybe the following day, and then the nurses will tell you, oh, that patient died during the night, and things like that. I think the other thing also that sort of helps is I can't remember if it was my daughter was telling that, the good thing about being a doctor is you don't carry your work home.
Okay.
I don't go with my patients.
Maybe in your head.
No. Once I leave the hospital, of course, I'll be thinking about some of the patients and wondering, okay, maybe we should do this, maybe we shouldn't have done that, and maybe tomorrow when I come, we need to do ABCD. But once you've left the hospital, it's like you detach yourself, you leave your patients, and then when you come back again, you're starting a new day with them. I think that also helps. Because I remember we had a lecturer that used to tell us that you can't cry over every patient. There are some patients where you really feel like that's bad. Yeah. And you want to cry and all that, but you can't do that. I mean, you have so many patients. If
Yeah.
you're going to cry, you remove your ability to be objective in the way you are managing the patients. Yeah. So even if you do feel so sad about losing patients, I think it helps the family also if the doctor is being strong for them. Then the doctor is also just crying, the family is crying, then you're wondering
everyone
now
is
who's
just-
helping who here. So
Yeah.
so you have to be strong for the family, and answer the questions honestly. If you don't know, we don't know. Yeah, rather than trying to cover up things. I think that's
Yeah.
that's important. Yeah.
Yeah. Okay. Thank you so much.
Yeah, thanks.
For this very enlightening conversation. I do know that there will be need possibly to come back and have another conversation, because maybe after people watch, they might come up with more interesting questions, and we hope that we can manage to catch you again.
Yeah. Yeah, catch me if you can.
Yeah, but thank you so much. We really appreciate.
Okay, you're welcome.